We're going to move on to our second delegation this morning, and that's the Cape Breton District Health Authority, and that's for the 2013-14 report to the community. And we do have Ms. Diane Calvert-Sims, the CEO of the Cape Breton District Health Authority, Dr. Rex Dunn, Vice President of Medicine, and Mr. Kendall Murphy from Strategic Projects. We've broken out the DHA presentation into 3 separate items because of making sure we could keep the focus by topic rather than one global discussion. And Diane is going to lead us off today, and I know as we go through that, and we didn't want to, given the importance of the topic at hand and given the seriousness of what we're about to talk about, I didn't want to try and put all 3 into 15 minutes that really we've allotted for 3 separate elements to that, so we can have a very full and engaged dialogue. So welcome, Diane, and we appreciate you joining with us today, and the floor is all yours.
Thank you, and thank you very much for allowing us to present today, and thank you for the introductions. You saved me 2 minutes. I'm actually timing my own self here. It is a pleasure to be here. This is our third actually presentation to councils. We've presented to Victoria County and also to Inverness. And it's part of the ongoing consultation that we will do in terms of reporting back to the community on the work that has been undertaken within the district, and also to give you some sense of future direction. In setting up the presentation, I thought it important just to put in context who the Cape Breton District Health Authority is, and why that's important is because we're about to undergo, as you know, in the province, significant change as we move to one provincial health authority. And so to give you the perspective and the understanding of what it means to have a district health authority and what it means in terms of employment. And as I was listening to the presentation from the Synergy Lewisburg, what it means in terms of tourism, because as you know, as tourists increase, so do the demands on healthcare services, especially as we look at some of our smaller facilities. The pressures on those in the summer is significant. As I started the presentation and we talk about Cape Breton District Health Authority, it was with tongue-in-cheek that I actually put the slide for the Cape Breton Regional Hospital, because that is often what people think we are, and that, well, you represent the hospital. But in fact, we represent the majority of Cape Breton Island, and even providing and supporting services that are provided by Guysborough, Antigonish and the Straits. So what I'll cover, I'm not going to go through the slide because there is a slide for each of these and you've had an opportunity to review it, but really a snapshot of who we are, where we are, what we've accomplished, and 3 key priorities that we have underway right now. So as indicated, this is the third council that we have presented to, so we do cover the 3 municipalities. Our population is declining, and we currently serve a population of about 120,000. We know, as I said, there's a swing in that with tourism in the summer, but that's the latest count that we had from Statistics Canada. We are served by a government-appointed volunteer board that represents different areas of the district, and the members, half the members, are appointed from the community health boards that we also have. We have 6 community health boards, which are advisory boards. There are feet on the ground, and I'll speak a little bit more to some of the work that they'll be doing in a minute. And we do provide not just acute care or hospital care, which is what people traditionally see, but you'll have heard about mental health and addictions, especially as we've entered into a fundraising campaign with the foundation to support our mental health and addiction service. We provide public health and community health services. We provide primary health care, which is predominantly our physician services. And we provide continuing care services, which is long-term care and home care and seniors care. Just a quick snapshot, we're one of 9 district health authorities, so we will be going to one provincial health authority. The second board that they are talking about is with the IWK. On your right of the slide, you'll see just a breakdown of where the community health boards are. So we have a Central Inverness Community Health Board, North Inverness, Victoria County, Northside Lakes, and the Cape Breton Community Health Board. And it's important to know who they are because we're just embarking on a consultation process with the community around population health and around what's important to the communities in terms of making communities healthier and helping people understand the factors that influence their health and what they need to do to be more accountable and responsible for their own health and how they can help us do that. We operate 484 acute care beds in 8 hospitals. We are the second largest health authority in the province. We have 15 rehab beds in our facility at Harbourview, and we operate 206 veterans and continuing care beds across 2 facilities. Our annual expenditure is about $297 million. We have 4,000 staff, and that's bodies, not full-time people. We have part-time, casual, and full-time. And we work with 270 physicians. That's both primary care physicians or your family physicians, as well as specialists. In looking at how we provide services and where we provide services, before we can make any decision, we have to understand who we're providing the services to and what it is that they actually need. So as we looked at our population health report that was released last year, what we noted is that the district continues to rapidly age, and this data is 2011, and we know that it's worse since then. So we're looking at about 20% of our population is over 65. As we look at education, we know that 20% of our adults aged 20 and over are categorized as low income, and that 34% of them do not have post-secondary education. And you may say, well, why does that have any relevance? Well, as we look at workforce planning and as we look at the professions that we need support in, that is of significance to us, especially if we want to grow our own and keep our own in Cape Breton. For population health, we note that 28% of adults aged 20 years and over are classified as obese. And then when you look at over 50% are classified as being physically inactive. So it tells us that we have some work to do in those areas. As we look at obesity and we look at inactivity, we know then that you're potentially at a higher risk for diabetes, and we know that one of the complications for diabetes is renal failure and kidney complications, and so that impacts some of our programming in terms of dialysis. So we have to get to the root of the problem and really start talking about health. From a strategic context, like you were about to enter, we've entered a significant planning time, especially in terms of budget. Everybody is constrained. We're already predicting a deficit for the end of this year, and we're working hard to minimize that as much as we can. We are looking going forward, what is it that we have to provide? Working with government, they set the direction for us in terms of what services through legislation we're required to provide, and then what are the provincial priorities, what are they focused on from the department, and then how does that impact us and what does that mean for the communities and the people that we serve. And just to give you some kind of scope, we're currently working on 24 initiatives across the province of Nova Scotia with other health districts and the Department of Health and Wellness. And so that consumes a lot of time and also resources. From a budget parameter perspective, we receive every year the parameters that we're allowed to work within, and that includes the amount that we may get in an increase or may not get, and it sets out exactly how we can make decisions, what services we can or can't impact, what are protected services, And within those parameters, we then enter into the discussion with the department as to how we will continue to maintain and indeed in some instances expand our services. A lot of our work over the last, especially the last 18 months, has really been focused around patient safety and quality improvements and trying to respond to the many changes that we see in practice and technology. And I will talk to you about some of those initiatives going forward. And as indicated, also going forward from a strategic context is the health authority structure. And it's important to make sure that whatever the structure is, it should support population health. And so how do we influence those discussions and how do we participate in those discussions and in that consultation process that our new Minister of Health is committed to undertaking. As we looked at that, when I came in 18 months ago, we had a 38-page, 5-year strategic plan. And what we agreed to do at that time was to try and make it a livable document for staff and also for community. And so as we look at our strategic framework, we've condensed it down to 1 page. And really what it tells you is this is the board established and approved strategic framework. And the work that is important that builds towards our organizational priorities, it's the organizational priorities at the bottom that I'm going to focus on today. So some of our accomplishments that I quickly want to cover will be the organizational structure and the service enhancements, where we are with infection prevention and control, what's happening in community health, what's happening with workplace wellness, and also innovation. From an organizational structure perspective, we've heard a lot about administration and reducing administration. We've been on that road for well over 3 years. We've gone down to a 4% administrative ratio, one of the lowest in the province, actually the lowest in the province, and one of the lowest in the country. Typically, an organization our size, you would see it around 5%. So it tells you we're on the right track. We have revised our organizational and reporting structures to ensure that at every site that we do have an administrative lead so that they can be the voice for that site and the point person for that site. We've been focused on reinvesting money in our frontline services, in our emergency departments, in quality, in infection prevention and control. We've redefined medical governance, and what I mean by that is how do we make sure that the 270 physician partners we have are engaged in the work of the organization, because people come to healthcare and come to acute care specifically for physician services, and it's physicians then that drive the work that we do. So it drives our surgical program, our emergency programs, our primary healthcare programs. And so we've done some, you'll hear from Rex around some of that work. And how do we ensure that we have physicians engaged in the work around quality and patient safety and infection prevention and control? So these are some of the service enhancements that we've undertaken over the last year and a half, and I'll just quickly highlight. So the review of critical care services and the change to create additional critical care capacity here at the regional hospital, and ensuring that Glace Bay still has sustainability for caring for sicker patients through an intermediate care unit. We've looked at our ambulatory care services, and we've had an external review of those services. And basically what that is, it's clinics that physicians will provide in our acute care facilities. Should they be there? If they are there, what do they require? And what do they require in terms of support? We've looked at our cancer services. While our cancer rates are not significantly increasing, the interventions are increasing, and the type of specialists and the type of interventions are increasing. And so we're running out of space, and we need additional resources in that area. So that's been a focus for us this past year and a half. We've looked at surgical services. How do we continue to sustain surgical services in Inverness? And we completed the review and the implementation of all the recommendations in that area, with the exception of one which relates to physician recruitment that Rex will be speaking to. And we've reviewed our emergency care services. There's new provincial standards for all of our emergency departments, and we have to make sure that we follow those. And they were introduced in 2013. We've just reported back on how we're doing, and we will continue to do that. We are expected to meet those standards by December 2014. We also have implemented a new care delivery model in New Waterford, and that's our collaborative emergency centre. So infection prevention and control is the one that I hear most about from patients and from staff. As we looked at infection prevention and control, we had two, as you know, we came out of a C. difficile outbreak, and we had the Auditor General's report in. Well, I'm pleased to report we've met all 20 recommendations of the Auditor General's report, and in fact have gone beyond that. We had a second review with representatives from the Department of Health and Wellness, and then also with Dr. Michael Gardam of the University Health Network, and we have met 36 of 37 recommendations that they gave us. What we've actually done is we've increased our numbers of staff in that area. We've increased education. And really what we've tried to focus on is changing culture, because infection prevention and control doesn't just rest with a few individuals. It rests with staff, it rests with public, and it rests with patients. And so a lot of our work has been around education in those areas and improving hand hygiene. From a cleaning perspective, we've added staff, we've changed our cleaning practices. And if any of you have had the misfortune of being a patient, I hope you were treated well. But we do have signage behind all our bathroom doors now which says this is the number to call if you're not happy with your housekeeping services, to make sure that we are responsive and we do keep the places that we work in clean. Interesting to note, Dr. Michael Gardam just did a follow-up visit with us, and as I said, he works with the University of Health Network, and he has told us that we are now one of the leading organizations in the country in terms of our infection control practices, so that's quite positive for us and for our patients. From a community health perspective, as I indicated, we've hosted education sessions for staff and public. We do run our Population Health Day, the Cancer Symposium, Living with Mental Health. And we're now going out doing community consultations on our Population Health Report. We're partners with yourselves on active transportation, and we work with a medical officer of health who advocates for and helps us influence healthy public policy. From a workplace wellness perspective, we're currently one of the top 100 employers in Canada. We've achieved Level 2 Healthy Workplace certification from the National Quality Institute, and this year we're going to be part of a research project around increasing positive mental health in the workplace. We've implemented a homegrown anti-bullying program that's reached over 1,000 staff. And you might ask, well, why anti-bullying? And it's to create that healthy workplace and to give people the confidence and the ability to have meaningful and respectful conversations. And we've also celebrated workplace diversity through initiatives such as Pride, CBDHA, and cultural diversity. And if you haven't had the opportunity, while it is an older YouTube video, I would encourage you to go on and watch It Gets Better. That was developed by our staff. There's our Pride CBDHA team. So recent innovations, we were awarded exemplary accreditation status in 2011. We'll be moving forward with accreditation again next year. And we've established a Patient Experience Advisory Committee in the summer of 2013, and the reason we did that is because we need to design services around what works best for the patient. And we're concerned, we hear the complaints, and we're trying to respond to those complaints. And we are going to be implementing some new initiatives that will really help us improve the patient experience. The New Waterford Collaborative Emergency Centre, we've completed the soft launch, and we will be rolling out with the communications to the community, and I think it's going to be a household mail drop to advise them that it is fully operational now, and that's both the primary care component, the physician component, as well as the mobile care team component. And then 3 current priorities. So just very quickly, the emergency department sustainability. We remain challenged in 2 of our sites, predominantly in terms of ED closures. A majority of times that is related to physician recruitment and physician availability. But 75% of the visits to our emergency departments don't require an emergency department visit. And so that tells us we have work to do in terms of ensuring access to people's own family physician or their own primary care physician, or in some instances a nurse practitioner. And it's important as we look at that and we talk about, so who is the collaborative team that should be working in community, and how do we ensure that people get access to the right person? It may be a dietitian that you need to see and not a family physician. It might be the nurse practitioner. It might be a physiotherapist. So how do we bring that team together, and how do we make sure that you see the right provider in the right place at the right time? From a health human resource perspective, our average district age of our employees is 46, so we're aging as well. We average 120 retirements a year. Some of the challenges are it's difficult to recruit to our rural sites, and it's difficult to recruit health professionals, especially nurses, and in some instances, some specialties of physicians, depending on the location. This year alone, we're going to lose about 80 RNs. We're on a recruitment campaign to recruit 100. We know that we may need 120 given existing vacancies. We've hired 375 in the last 6 years, and with that comes significant costs. Every RN we say that comes in takes from $25,000 to $30,000 to recruit. So you can imagine the impact on the budgets in terms of recruitment and orientation. We are working in partnership with CBU and other educational facilities to ensure that they can help us prepare for meeting the workforce of the future. So Rex?
So what we'll do is just go through the presentations. If you can keep your notes or comments at that time, and then we'll come back to Q&A if that's possible, Diane, and then we'll work jointly just so we keep the flow going. Welcome, Dr. Dunn.
Thank you. Thank you, Mayor Clark, councillors. It's an honor for me to be able to talk on one of my favorite subjects here today. In my job at the hospital is to do mainly with physicians, and anything you do really with clinical services and primary care and the delivery of that care. So I would say I spend a good 50-60% of my time in various issues around physician recruitment, retention, and other issues. So just click it, there we go. So just to give you, my goal here is just to give a fairly brief overview, and hopefully we'll leave time for some questions. I do find that citizens in general are very curious about perceived shortages and issues around physicians, and it's no wonder. We all have a family doctor. I hope we do. I think that most of us probably have seen specialists, so access in a timely fashion to the right physician at the right time is one of the key features of any good health system. So just to give us a little perspective, I've been here in the district over 30 years, and when I came here, it was less than half of our current physician complement that we have in Cape Breton Island, yet we have less people, so you kind of wonder what's that all about. And of course the reason is specialization, more services, and other changes in the way physicians approach their practice. It's just a different world. For many, many years, physician recruitment was basically left up to practicing physicians. If you felt you had a room in your practice for somebody, you scouted around, got somebody, opened the doors, arranged for them to work, and that's all there was to it. It became more complex when specialties became more complex, and when the government started to get a little bit more involved. But even then, for many years, it was a somewhat secretive and mysterious process. How do we get these specialists here, and how do we get them working? What do we have to offer them? All of this is changing rapidly in the past few years. It's a much more open process, and I certainly am much more in favor with this process, trying to eliminate competition between districts for physicians, secret little packages being offered by one but not the other. This is all, fortunately, going by the wayside. The government has stepped up and assumed much more control of the whole process. And this happened long before there was talk of one district for the whole province. Currently, the physician resource pool is being referenced to a plan that was produced. It's a very good 10-year review of the current situation and what it probably will look like for every specialty and every location in the province for 10 years. So this is the guide that's being used by provincial advisors. Every new recruit, whether it's even to replace somebody that leaves or whether we think we can justify a new position, has to go up the line and actually have deputy minister approval. We get a letter back, comes to the CEO and then to the rest of us, yes, you can now advertise and recruit. We haven't gone as far as some other provinces in restricting billing numbers. That hasn't happened. There's no talk of it. But in a sense, the vacancies are still being controlled now at the government level. The numbers are there on the screen. Diane alluded to them before. We have 236. It varies according to the day of the week a little bit, but overall about 235 physicians on a permanent basis, and a number of locums. Physicians are a mobile group today. They come, they go, they do locum for a while, they practice in one area, and for own personal reasons change and move to another. So this is a quick breakdown of where we are right now in primary care. You can just see the areas there. The Cape Breton Healthcare Complex, which includes all of the towns in this area, 102 primary care, so overall 102 primary care physicians and 116 specialists. When I tell my colleagues on the mainland that we have 116 registered specialists on the island, they're quite amazed. Recruitment, well, this is where we've been in the past year, 2013. 5 new family physicians on the island, 3 GPs and 2 emergency rooms. And here's a list of all the specialists that have been recruited and are working here at this time this year. On the flip side, some retirements and some relocations, but still a net gain there. I think I did the math at around 8. Where I'm very pleased personally with the way all of these new people are fitting in to the community and building up practices very quickly and discharging their responsibilities very well. So here's our list of vacancies, and I have the 2 columns here because, as per my comments about the process, you need to have approved vacancies to actually recruit. So family practice, primary care is always a bone of contention. We feel we need probably, we're listing 5 there. We feel we probably need more than that. It could go community by community. But so far we officially have 4 open positions. Right now it's not an issue because we still haven't been able to fill those. At some point they will be filled. In my head, I think we're going to get there. And then we'll be getting into a more serious debate with government as to where we're going to put people and where there is truly a need. Internal medicine, right now we have a perceived vacancy for 1 general internal medicine specialist, and probably another one will happen this year, so that probably will be 2. Currently we're debating with the government to approve a position for a rheumatologist. We still have a position open for pathology, radiology. Emergency medicine is one of our biggest deficiencies right now. There's been a relocation of manpower in that area. So the shifts are a little short, and you see that in the newspaper almost every day, that there's a closure, and this is one of the reasons why. An unexpected departure of a cardiologist has left us short, and we think we need another one, but we are advertising for one. Hematology, palliative care, we're looking. So I talked a little bit about incentive packages. So the province has an ever-expanding list of incentives for physicians. For an approved position, they pay all the costs of a site visit for them and their families. They have relocation support, debt assistance programs, a new family medicine bursary, and we have a couple of students here now that are under that program and will work in Cape Breton. There's a number of special return of service contracts. There's a number of incentives to stay in an area, quite a long list of those. And plus we approach students in the various levels of training. We see a lot of young students here. There's no substitute for visiting an area, getting to know the physicians there in terms of a recruitment tool. It's probably the best thing. And there's advertisements, job fairs, clerkships. At the district level, we still offer additional relocation support if it's necessary, sometimes office support. We help people get settled, offer support for accommodation, car rentals, some education programs. But I do see there's a gradual shift of funds for relocation support and recruitment from the district, which used to have pots of unbudgeted money, to more structured programs which will be administered by the government. That is a definite trend. So what lies ahead here? Well, we're starting to enter into new territory. Overall, people are surprised to learn that in Nova Scotia, if you look at Canadian statistics, we have the highest physician-to-population ratio of any province. One of the issues is the percentages of primary care to specialists, however, are inverted. We should be having more family care, primary care physicians than specialists, and yet we are in the reverse position. So this is one of the efforts of the government, is to try to steer recruitment in that direction. For the first time in living memory, we probably have an oversupply of specialists in certain areas. There are orthopedic surgeons in this country, quite a large number, that cannot find a place to work. Why is that? Well, medical schools have ramped up their production about 20% over the past 5 years. And we are seeing fiscal restraints in many provinces. A lot of these specialists require quite an infrastructure to work. It just may not be there. So that we're starting to see this. Now, there are a lot of specialties not yet affected, but there are some that certainly are. We're seeing a lot of younger students interested in primary care, even being cognizant of the fact that we have an older workforce, same as nursing and many other healthcare specialties. Even factoring that in, it does appear that we will, over the next few years, have enough physicians to fill our needs. Another thing that is changing is the old family doc that used to work 365 days a year and be on call. There's very few of those left. Today's graduate wants a more sensible work-life balance. They want to work in a collaborative practice. Many go for salaried positions, and they like to have a situation they can just walk in, see their patients, and not be bothered with all the administrative stuff. So we're trying to work toward that, recognizing that, but at the end of the day, you probably need more physicians to do the same amount of work if you go down that road. I'll leave it there, and hope to answer some questions at the end. Thank you.
Thanks, Dr. Dunn. And we're pleased to welcome forward Kendall Murphy now on patient flow. Welcome, Kendall.
Thank you. And thanks everyone for giving us the opportunity, I guess, to come and speak today and talk about some of our different initiatives within the district. And thanks again for giving me the opportunity to talk about one of what I'd say is probably been one of our biggest challenges over the last 18-month period that Diane alluded to. But what I'd like to do is share a little bit about our journey to make improvements in the area of patient flow. And I will say that my background isn't clinical in nature, so I sort of do project management work for the district. And what I'm really here to do today is share the work of our teams who have been sort of working in this area. But I think it's important that we acknowledge some of these successes we've had, but also to keep our eye on what are some of the challenges or obstacles that we're going to have to keep looking at going forward. So I guess really throughout the presentation, just to keep in mind, there's probably two key things that I'm here to sort of leave with you today. One is to sort of just to share this information in terms of what we see as being some of the priority areas or key things that we need to focus on around patient flow. And the second is to keep in mind that if down the road we might come ask for some support in terms of working with our district to make some changes, because we recognize that patient flow is something that really spans outside of just the control of the district health authority. It's about working with everybody in the community, our partners. So with that being said, I just kind of wanted to step back for a second and say, when we're saying patient flow, it really is exactly what it sounds like. We're talking about how do we move patients through our healthcare system. And in particular, a lot of the time we talk about the acute care end. So a patient is in hospital. So how do we move patients through our hospital when they are there to receive some sort of treatment or services? So basically, it's our beds available when we need them in hospital. So what I want to talk about, I want to take you back to when we really first started experiencing some above average demand or some real challenges in the area of patient flow. And we'll go back to the fall of 2012. And what we were really coming down to or saying as a district, and everybody really was voicing this opinion, is we just don't seem to have the beds available to move patients through our system, through our hospitals. And these pressures were really being experienced by a number of key stakeholders. So I kind of want to share with you what we mean when we say we were feeling these challenges. I'm going to share some different perspectives. So the emergency departments. So what this basically meant is you're sick, you go to the emergency department, decision's made that you should be admitted to a hospital bed. But at the end of the day, we can't get you moved up to one of those beds because there just aren't any available because there are other patients in them. Our inpatient units were feeling the same sort of burden because they had the emergency department, for example, come to them saying, we have patients that have to get up to your unit, but their reality was we have patients here and we have nowhere to go. We can't send them home right now. Our operating rooms. So if we look at elective cases, so basically scheduled surgical cases, what we were experiencing were situations where you've been booked or it was identified that you needed to have some type of surgical procedure. So you're on a wait list. The time comes up and you actually have your appointment booked, so you know that date is approaching. But when you'd actually get to that date, what we were finding in hospital is that there were occurrences where we had to cancel that last minute because, again, we just didn't have a bed to put you after this, for you to go to after the surgery. So again, challenges for patients in those areas. Communities in terms of nursing home placement. Patients who are waiting, or residents or clients who are waiting to go to nursing home beds, they're either at their homes or sometimes they're in hospital beds. If they're in hospital beds, the challenge is that we don't necessarily always have nursing home beds to send those patients. So again, where we were experiencing challenges in this area was, in the nursing home end, is we're trying to get these people out of hospital to make space for our acute care patients, but again, the placement side of things, or the nursing home side, is saying we just don't have the beds for those patients. Infection prevention and control, as Diane had mentioned before, we've been making great strides in this area. And what we've been, patient flow has sort of been looking at almost conflicts with what we want to do with infection control sometimes, and which is we want to limit patient movement because we don't want to be moving patients around and risk them getting exposed to different illnesses and diseases. But with patient flow, our challenge is we're trying to make beds available, so we're trying to move people, and so it's kind of a balancing act. And I left it, and we have patients actually left to the end here, although we know that the patient always comes first, but it's more or less just for the impact factor. But most of all, this was a serious impact for our patients. So I want to share a little bit of data to show again why we say we had a challenge back in November of 2012 through to actually, in recent months. So there's a graph on your screen that shows the number of days a patient has spent in the emergency department following a decision to admit from April 2011 up until March of 2013. And the scary thing, without getting into this in a whole lot of details, you can say there's a pretty steady increase in terms of those days each month. So what this is telling us is that we were having more and more challenges moving our patients out of the emergency department over that period of time. So we are in fact providing them care in what is not the most appropriate setting in our emergency department, and therefore we can't get them up to an inpatient bed. And I mentioned the operating room and our elective cases being canceled. So if we look at this data over the same period of time in groups of 3 months, we looked at how many cases were actually canceled because we didn't have a bed available for those patients. And as you can see, over the same period of time, we were seeing a similar trend. So again, for our district health authority and our patients, this is concerning to us. So our next graph, and as you can see, the trends are very similar in a lot of these, but we want to look at our number of clients waiting to get to a nursing home, and this is both in the community and in hospital over the same 2-year period. And you can see over that period of time, we've gone from about 400 clients waiting to get into a nursing home in our district up until over 600 over a period of 2 years. And actually, in the period since that, I will say we're probably up over 700 now, so that's continuing to grow, and so that's a concern. So one of the things we look at the district, or we do have the option of putting, or getting some of these potential nursing home clients into a different type of bed in our hospitals, and these are called transition unit beds. So we do have approximately 50 throughout the district. But what this graph illustrates is how far above 50 we were over that period of time. So although we only have 50-some beds available, we actually had, for a period of time back in November of 2012, we had 140 patients who were in our acute care beds, but were actually not requiring acute care services. They were waiting to go to a nursing home bed because we just didn't have the nursing home beds available. And so just to note, some of the compounding issues, I mentioned the nursing home, the placement issues, but what goes alongside as being another factor really is our ability to get our sick patients out of our hospital beds at the, on our end. From the presentation this morning, they talked about they wanted to increase the length of stay in Lewisburg. Well, we want to decrease the length of stay of our patients in hospital. And if you take a look, just to bring back, because infection control has been at the forefront so often recently for our district, again, we have the conflicting issues with patient transfers, and we have to manage those infection control challenges in addition to our patient flow strategies. So I talked a little bit about the state we were in, and I think it's important that we share that information because it's important for all stakeholders and patients and members of the community to know that this really is our environment right now. But I do want to share some of the changes we've made in recent, probably over the last close to a year now, but we've been working hard at some different strategies to sort of make a difference in this area. And I will say that there's one main focus or a theme sort of behind this, and I'll explain the strategy on the screen, but it's really that the best place for a patient to be is, even if they're going to a nursing home bed, is to be home, if at all possible. So what we want to do is keep people home as long as possible. So what we set up in the district was a strategy where we looked at a number of different facets, but I only want to talk today about the issue we're having with the number of people who are waiting to go to a nursing home bed in hospital. So what we figured, more or less, and what we've seen other organizations do, is to focus on your overall objective, which for us is to move patients from the emergency department to an inpatient bed in a timely manner. But to do that, there's a number of different factors we have to address. So we have to address the number of patients who are waiting for placement in a hospital bed. So our district has looked at a couple different strategies over the last little while, and I just want to share briefly what some of those strategies are. So we've established something within our district called a joint discharge operation. And what this really is, it's a opportunity where cases, or not cases, but we're looking at patient situations who are in hospital. Their acute care episode is ended, so they're no longer ill, but there's complications in trying to get them back to their home. So in the past, we may have, and we still do in situations where we need to, but we'll allow them to wait for placement in hospital. But the purpose of this group that meets on a weekly basis is to go through those, look at those patients and say, are we really exhausting all opportunities to get them home? Because at the end of the day, it's best for the patient to be home as opposed to in hospital. And something else we had set up, which is sort of used through this joint discharge operation, are some changes in sort of our continuing care philosophy or our continuing care programs. Continuing care being how we provide care to patients or how we provide services to clients in their homes. So we have different programs, one being Home First. So what has happened is we've actually have the ability to authorize home care services well above what we've been able to do in the past if it means we can keep somebody at home as opposed to keep or have them wait for a nursing home bed while in hospital. At the same token, we have another program called Home at Last, where we have funding available to get patients home quicker when they've been in hospital for a little while, perhaps with an acute episode. They need to get back home, but maybe they need some help getting their prescriptions picked up. They may need to get a light grocery order. They may need to drive home from the hospital. It's basically anything we can do to get those patients home. And the third thing is we actually have a group or a task force that's set up where we collaborate with some of our external partners. Where we have our partners from the Department of Health and Wellness, from the Department of Community Services, Adult Protection. We're looking at mental health and addictions. Cape Breton Housing Nova Scotia all sit at this table. And as well as we have had membership from each of the municipalities. And Bernie White, who I believe is retired now, actually had sat in a couple of our meetings at the end of last year. But what this group has really been doing is coming together and brainstorming what are some of the things we can do as a group to make a difference and sort of help out with these patient flow challenges. And that work is really just unfolding now. So I kind of mentioned before, one of the asks maybe down the road is to sort of collaborate with us on some of these activities. So I just want to wrap up a little bit here and kind of show, well, where have we gone over this period of time? So I set the stage before saying we were in pretty bad shape back in November of 2012. Well, over that period of time, if we look at the number of patients we've actually had waiting in hospital to go to a nursing home, through some of these strategies, we've actually been able to reduce the number pretty significantly over that period. So I'll say we were as high as about 143 clients are waiting to go to a nursing home bed at one point in October, November of 2012. Well, we've recently dipped down, so we're only at about 80 right now. So if you can appreciate, over a relatively short period of time, we've made pretty big strides in trying to make a difference in that area. And so as I mentioned before, this really links back to our overall patient flow strategy, where at the end of the day, our goal is to move patients from the emergency department to an inpatient bed once they're admitted in a much more timely manner. And so the graph on your screen shows, in gray, it's where we were last fiscal year, so fiscal year 2012, 2013, versus this fiscal year, which is in green, which is 2013, 2014. So the easiest way to look at it is the green bar being higher steadily through this year indicates that we're moving in the right direction. We are, in fact, moving patients to an inpatient bed in a much more timely manner. If we were to revisit those inpatient emergency days that I had showed at the beginning when I started presenting, that number is also down significantly. It's actually below any of the points that had been in the last year. So I will mention, just as a point, is this is a learning process. So although we're making some great strides, we still recognize that there's a lot of work to do. And again, keeping in mind that it's beyond just a district health authority challenge, probably, and we have to work with our community partners. But what we've really recognized is that through this hard work to keep people at home, we're actually just shifting the burden from our hospitals to back into the community. And what I have some listed up there, some hours used by home care agencies over the last 2 summers, really. You can see there's a pretty big increase in the number of hours of services authorized to these patients or these clients who are at home. So what this means is that as a district, and probably in working with our external partners and our agencies, is to figure out how do we make sure that we can, we say we want to keep people at home, but how do we make sure we have the services in place to keep them at home? And so I guess with that, it's to keep in mind that over the next period of time, we have to really, we've started down the journey, but we really have to keep our foot on the gas, I guess, and really look to continue making strides in this area. And again, as with external partners, as we continue to explore some of the challenges or some of the things that have been coming up through our internal joint discharge operation and at that task force table, we may have to start bringing back to the table things like housing and challenging behaviors, and what can we do in our communities to sort of keep these people at home. So I guess that's, we'll turn it over to questions right now, so maybe I'll ask Diane to come back up for our, trying to get out of the questions.
Just before we do that, if it's possible, I just would say, Kendall, we've had 3 very good presentations, and what I would recommend, just given the topic, if we could just recess for a few minutes to give people a quick break and then come back to the questions, if that's okay with our guests. I just don't want to rush this along. So if we can just recess for 5 minutes, and we'll be back for Q&A. And continue with the question and answer format to the presentation by the District Health Authority. And to start off the process, we're going to use the center podium for our guests that are with us today. But first up is Councillor Cormier for questions.
Thank you, Mr. Mayor, and thanks for the recess. I went in to get a coffee, and they asked what we're doing and where we're at in the meeting, and I said we're doing a regional hospital situation, and Sharon, one of our employees up there, said, you're not a very fast learner at Cape Breton District Health Authority. Yeah. But anyhow, I have a few questions, nothing serious, but I don't know who's going to answer them, but it's interesting to note that the perception and statistics don't really match up, with double the physicians. I'm just going to go on for a few minutes, and then you can answer the questions. Double the physicians in 30 years, and I know that's inverted, but still, statistics and perceptions are really different there. And Dr. Calvert-Sims, I was at the CEC meeting in New Waterford in September, and I thought you handled yourself very well. It was sort of a lion's den because people are really concerned. You obviously drew that conclusion. But when there's a provincial election a week later, there's other dynamics that were into that meeting. However, and I'll ask you a couple of questions about that, and I know I wasn't ready for you to say that you got a communication going out, which is great, and you're saying that it's up and running, and that's really good, and I'll ask you a couple of pointed questions about that. One is that I talked to Dr. Littlejohn. I sort of put him on the spot at that meeting. He's my next door neighbor, and I asked him, what would it take to get this CEC in full operation? And after a little, he's quite winded, as you know. I had to ask him again.
You said that.
I had to ask him again, what kind of manpower do you need? And he indicated one doctor, and at that point, 2 additional nurse practitioners because you had 1. And so I'll be asking you about that. The other thing is the perceived doctor shortages, perceived and what you're allowed to actually recruit for. And I guess 16% unemployed. I didn't realize that. Hopefully that'll work in our favor as we go forward towards recruiting. And with the nursing homes, it's encouraging to see that you're getting people placed in nursing homes from where you were and to where you are now. But I assume that placed in nursing homes doesn't mean necessarily placed in the industrial Cape Breton. Could that be Bedeck and places like that? Because I have a particular constituent, and it's really sad. Her husband in the 80s is in Bedeck, and well, he might as well be in China because she hasn't got the access to visit him and that, and it's really sad. I know it's not, I'm not blaming anybody, it's a fact of, a sign of the times, but when it hits somebody personally and somebody calls you about it, it's hard to take. So anyhow, I guess I'm more concerned about the, you don't have to let the cat out of the bag on New Waterford because you got a release come, but I'd like to know if we do have another doctor and if we do have 2 nurse practitioners. Thank you.
Thank you, Councillor. Who would like to address that, or do you want to trade off? You can share any responses as well.
I'll start with New Waterford, and I actually haven't seen the draft of the release, so I can't tell you. I'm just thinking, have we hired we had 1 that was in interview process or in recruitment process for the nurse practitioner, so I can't tell you if that's been awarded or not been awarded, but I can certainly inform you of that afterwards. And it would be included in the release. I'm going to ask Rex to speak to the physician recruitment, if you wouldn't mind.
You raised a couple of points there. One is the 16% thing, and that really only applies to specialists across Canada. So as far as primary care is concerned, we still have open positions. Right now, there's an open spot still in New Waterford. There were names, as I understand it, brought forward at that meeting of physicians. Not one of them was really panned out to be a real opportunity. and we did look into those. So we've had some other inquiries, but there's nothing definite yet. There is one physician there who's indicated that she might even leave, so things could get even more unsettled for a while. You mentioned the nurse practitioner for the CEC, and that's an interesting situation because they're also short in Glace Bay of physicians, and one is leaving this month, as a matter of fact, who has a nurse practitioner. And the community has great value on this person who has a fairly good practice and has been working hard to try or see her stay there. And she's kind of caught between these two realities, so I don't know how that's going to play out yet. There's pluses on both sides and negatives on both sides. So was there another question about recruitment that? No, that's fine. Okay, thank you.
Just to add, around the communication, because this is a three-party communication, Department of Health and Wellness and EHS and ourselves, we're tied to predominantly the Department of Health and Wellness timelines and announcements, so we have to follow the direction. That's been
Okay, thank you. Thank you, Councillor Cormier. Now recognize Councillor Prince.
Thank you very much, Mr. Mayor. Dan, you probably never had the chance to talk on page 37 about your questions. Is the information useful? Well, I believe, and I believe the council believes, that it certainly is. And you also asked, are there other opportunities to partner on Pacific initiatives? And you mentioned housing, physical activities, and I would suggest a smoking policy that we're going to discuss later. I think there's ample opportunity for the CBRM Council and the District Authority to interact on some of these issues. Now, all three presenters touched on this issue, and that was about the emergency department sustainability. And because I'm from the north side, I'll mention the north side. There's frequent closures advertised in the paper about the closure, and it may be due to a lack of physicians and everything else, but we heard today is not necessarily always the case. Some people think that's a segue to the Northside Department possibly permanently closing, but certainly that's not the case. But after a promise by a previous government to cut down or eliminate all emergency closures, they feel a mistrust there, and hopefully that will not continue in the future. But there's a fear out there and a concern that they're not, I know they can go to Sydney Dale patients, but I think there is a concern that they're not getting the treatment or the health care that they feel that they're paying for. You may comment on that, but the specific question I'd like to ask is, when you talked on page 19 about your strategic context, and you talked about quality improvement, you said the health authority is committed to meeting its obligations of patient safety and quality improvement, and this particular sentence, and to respond to continuous changes in practice and technology. What does that actually mean? Does that mean additional training if necessary? Does that mean new equipment? Could you just elaborate on that just a tad more?
Well, one good example of changes in technology and new equipment would be the introduction of a MRI in Inverness, and we did advocate for that over a 3-year period. Just looking to Rex to make sure I get the right number of years. Over a 3-year period, it was supported by a medical advisory committee as an important piece of technology to support the physicians and the patients on that side of the island. So monitoring those things, changes in practice. If we look at renal dialysis, there is a movement to more home dialysis for the right patient, and so making sure that we're ready and prepared and able to do that. And we actually started that last year, increasing the numbers of patients, so things like that.
Okay, thank you. That'd be it for now, Mr. Mayor. Thank you.
Thank you very much, Councillor Prince. Recognize Councillor George MacDonald.
Thank you, Mr. Mayor. And again, while Kendall was giving his presentation, I was kind of smiling, and I told him I'd certainly ask this question later. I don't know who can answer it, but it's not really a question, just a general comment. But he mentioned the getting patients out of the hospital into nursing homes, for example. And I'm also on the board, at least for now, at the Seaview Manor in Glace Bay. And usually when we meet, the hospital is sort of the arch enemy. They're trying to get the patients into the nursing home, and the nursing home is trying to keep them out. because especially with infectious diseases and so on, we have, maybe a room empty or a double room where there's 2 patients, and so almost every meeting I go to, even yesterday I was there, and it's almost like you guys are, like I say, the arch enemy. We're trying to keep you guys out, and you're trying to get the patients in. And I know sometimes the province get involved and cuts off our funding because we won't take patients and so on. I don't know if you want to comment on that. It's just kind of I'm smiling, but it's not funny. I know it's just every meeting we go to, they say they have some patients, we don't want to take them, and they want to put them in here and so on. So that was one question. The other question I had, and again, I've been around this a few years. I remember back when John Malcolm would come to Glace Bay with his presentations. And that's when the emergency room was always lined up, and there was always talk of, I have the wrong terminology, but it was called a drop-in center. I know there's one in Sydney where you just go and see your doctor. Well, I don't know what the proper term is, but I know there was plans at one time for Glace Bay, and I know the one in Sydney is working out well, I think. The one at Glace Bay is kind of not the same type in a sense, because I think there's regular doctors there and so on. But I don't know if you want, but that seemed to me to be an ideal way to get if somebody who hasn't got a doctor. Because as you know, the problem, even though you mentioned education, the problem in Cape Breton is that everybody goes to emergency probably when they don't have to go there. And I'm probably I have a doctor. In fact, my doctor is actually a personal friend of mine. But if I get a sore throat today, or even not strep but just sore, it would take me about a month to see him, even though he's a friend of mine, and I'd have to go to emergency. So we always talked back in those days about, I guess, educating the public. But again, just a comment, but I guess maybe somebody could comment on the nursing home situation if you want to, or I just wanted to mention it. Thank you.
Yep, sure. I think it's an excellent point. I think that our objective really when we're trying to place clients from hospitals, that we are only identifying patients that are suitable for nursing home placement. And I think we recognized, and I was actually involved in some work a couple of years ago where we started to uncover a lot of the challenges we had in that transition from hospital to nursing home. And I think it's probably still a work in progress, where we recognize that there's some things, probably on both ends really, that we have to make sure we have in order when we're moving through these placements. And sometimes it may be in the process that it may be on our end where we're not uncovering something, or we don't realize something, or something doesn't come to our attention until we're down the process and trying to put them in, trying to place somebody in nursing home inappropriately. But I do know at least that work is still ongoing, so we do recognize that it is a challenge, and hopefully we'll have a smoother transition process as we move forward. So it's a good point, though. Thank you.
Thank you very much. Now I recognize Deputy Mayor Sakry.
Thank you, Mr. Mayor. I guess I'd like to touch on basically what Councillor McDonald has touched on, and that's the walk-in clinics. There's one at Kings Road, am I correct? And did you mention, is there one in Glace Bay that maybe
Not really.
is it a clinic or just a doctor's office? Just so happens there's 2 or 3 of them in the same building.
This situation works best if a group of family doctors just opens their office in the evening hour, so that anybody that has kind of an urgent thing that's in that practice, the records are there, there's longitudinal ongoing care. That's the best model. Walk-in clinics exist in almost every urban area in Canada simply because of the reason that you already mentioned, but it's not the best model of care. We recognize that here in Sydney, and it kind of started up because of various pressures. But there's not always the best communication between the physician who sees you there, the one that might see you the next time, and the record and so on. So the best model is if the physicians somehow improve access. And there are physicians here in Sydney that do that, and I think there's some in Glace Bay that open their office certain nights a week, and then other nights to accommodate that. But you're right, it's not really organized into a system.
So maybe that's something the health authority wants to take a serious look at. And I'm hinging that on the 75% that are in ER that you're saying shouldn't be there because they're not considered emergency response.
That's an interesting point, and we've looked at that, and there's some odd liability issues around that. Once the patient comes in and registers, you now have some liability for that patient, and if you send them without them having been seen by a physician to a walk-in clinic without being certain how that's going to work out. We did run into some objections from our legal people, mainly on the nursing side, who consulted their union's lawyers. So it seems like a logical solution, refer them over to the walk-in clinic.
Or that maybe the health authority can look at having their own walk-in clinic.
Well, we do support the one that exists to some extent right now. Whether that's the final answer, I still think the better model is to have the physician groups open their offices, as some of them do here in town.
So,
Sorry, go ahead.
and I guess I don't want to miss my point I want to make, and that is, speaking from experience, I recall going to ER at the regional hospital. Had the flu real bad, found it hard to breathe and that sort of stuff. So after I sat there for 4 hours, and I seen people coming and going, I said, okay, well, it's pretty obvious there's people a lot more sick than I am. So I just went home. And then I started thinking about all those other people that go with the similar situations, and unfortunately maybe the odd person may pass away as a result of that. That is a concern, and I'm saying maybe the provincial health department should look at implementing some sort of program that's able to address the so-called non-emergency issues, that people can at least get some sort of minimal care in terms of a response to what their issues might be. And another case was I was doing some work, cut my finger that required 2 or 3 stitches, and I sat there for 3.5 hours. And I'm saying, okay, it would take, about 5 minutes to stitch that up and see you later. But I just think there's people getting lost. There's people that are sick that may not appear to be sick because they're triaged and realize that when they come in the door. But superficially, they look, there's nothing serious in terms of their signs of their bodily issues. But for me, I think the provincial government needs to look at implementing, if it's a walk-in clinic, or create some sort of incentive for doctors to open clinics and work that in conjunction with the health authorities.
Yeah. Well, okay, go ahead.
So that ties nicely into the work that we're doing around primary health care, the collaborative teams, and also the collaborative emergency centre. Because when we talk about a collaborative emergency centre, a component of that is improved access to your family physician. And so it's asking family physicians to change practice and to leave appointments open, so that if we can refer to them, or if we can tell the patient, you don't need to come to the emergency department because your family physician has appointments available tomorrow, that we can do that. There is research out there that shows that if physicians change their practice and do keep open appointments, that it does work. We have a family physician here in Sydney that does it, and he talks about it wherever he goes. And so there is work currently underway in the district and in the province around creating better access to the family physician through open appointments, because it reduces the wait time and it gets people in quicker, and it keeps them out of the emergency department. So keeps them alive.
Thank you, Deputy. I now recognize Councillor Dethridge.
Thank you, Mayor Clark. Just more, I guess, some comments, because Lowell had brought up one of the issues I wanted to talk about. But going back to your slide on 26, you talked about the average age is 46 years. And I guess first of all, I want to thank each of you for bringing this presentation forward today. A lot of great information in it, and I thank you for that. Getting back to the 46 years, and the 375 RNs that you have hired over the past 6 years, I think, oh my dear, what a lot of talent went out the door, and new talent has come in. But the day of nursing, the way, I guess, I nursed for 37 years, and I see so many changes just in my 7 years since I retired from the hospital, and it's just a lot of talent and a lot of expertise has gone out, and it's the same with the doctors. When Dr. Dunn talked about the ones that are gone, the ones that are coming in, such a lot of changes. One of the issues, I guess, that Kevin brought up with regard to the walk-in clinics, and I really like Dr. Dunn's idea with regard to family practices opening up their clinics in the evening. And I say that because I look at the walk-in clinic, the one out on Kings Road. I was there with my daughter about 2 years ago, and myself with a really bad chest cold about a year ago. And I thought, if I don't catch something worse than what I got right now, before I leave here, I'll be doing good. They're not really, I don't think they're a really safe place to go when you're really, really sick, because you're not getting that expertise that you would get in ER or with a family physician. And you never know, if you're told to go back the next day, you don't know who's going to be there, because there's no consistency to it. The other item I just want to make mention of is with regard to the home care and the clients that are taking up hospital beds that should be in nursing homes. And you talk about sending them home, and it's called Home at Last. Just a question with regard to that as to who is responsible if I'm in a bed and I'm in my 80s and I can barely care for myself, and you're sending me to my home, and there's no family to look after me because they all work and really don't have time. They're expecting their mom to be kept in the hospital, so you send them home. Who does the home care for them, and the meals, the baths, the meds, and who does the monitoring? Because the home care service, I'm looking at the hours. Do they come in and stay with you like 24 hours nursing care, or is it just 1 or 2 visits a day?
So with the way home care is authorized, it's basically on a needs basis that's looked at by one of our district's care coordinators. So they'll go in and they'll take a look at the patient, or at the individual or the family member, and say, here's what, based on your situation, here's ultimately what we think the needs would be. And they can authorize up to, in the past they've been able to authorize up to a certain number of hours each week, and I don't know the number off the top of my head, but it's through Home First that we've actually been able to increase those hours if it means that we're going to avoid a potential hospitalization to wait in hospital. Now with respect, there is no 24-hour care that can be authorized in the home. And one of the issues we were having the discussion before is around, a lot of the concern seems to be around overnight care in particular. And although different types of overnight care could be authorized, it's always a matter of whether or not the agencies have the resources available or the ability to actually provide that type of care, which is certainly still an obstacle that we're facing.
Okay, so there is a criteria, though, that has to be met before you would send someone home, like
That's
they
right.
have to be steady on their feet type of thing? And
That's right. So what we look at, and I mentioned before the joint discharge operation, so we're looking at some of these complex cases where, we're wondering, is there really a discharge plan possible to get them home? And the reality is that we make sure that we're avoiding dangerous, putting someone home in a dangerous situation, and which is really why we end up in the situation where we do, because we don't want to put people at home in danger, so we end up leaving them in an acute care hospital bed as opposed to that.
And just one other quick one.
Yeah,
So
sorry,
go
Councillor, you
ahead.
have to just come back for supplementary.
Oh,
Your time went out there. So we'll come back. I recognize Councillor Elder MacDonald.
Thanks very much, Mr. Mayor, and I too would like to thank all 3 presenters. Just a couple of quick questions, I guess, and then I'll let the chosen parties, I guess, answer them. In relation to the nursing shortage and the people that are retiring out, has there been any discussions with the university? I'm not sure how many people they graduate on an annual basis, and has there been discussions in regards to increase in intake, if that is possible? I'm just wondering about the 811 number, and I think I have that right in regards to people that can phone for medical help and assistance and proper direction. Wondering how that's working, and if that is looking to be improved upon to make the public more aware. There's also a new business that's opened in the downtown area. I believe it's called Home Instead. And I'm wondering if those are the types of partners that you're engaging with in regards to people wanting to stay home instead of course, going into nursing homes or the hospital. And the last one would be in regards to, we always hear this, I don't know if it's true or false, the equation of, no, I want to leave my mother in the hospital because she'll get placed in a nursing home quicker. If I take her home, she'll be home forever and she'll never get in a nursing home, so I don't want her at home. Just leave her in the hospital until she gets placed. Is that a fantasy, or is it factual, or is it just rumor, or how does that work?
Should start with the last one first. There are occasions that happens, that people would rather have their relative left in hospital. Our position, certainly even before we were experiencing the pressure, one of the things that we learnt with the C. difficile outbreak that we underwent is that the people that are most at risk are male, over the age of 65, who've had frequent hospitalizations or interaction with the medical system and have had multiple antibiotics. And so given that we know that, and that they've had extended lengths of stay in hospital, so given those factors, when we look at the population and our aging population, the first thing we want to do is make sure you don't come in. Because you could have a community-acquired C. difficile. It's not always in hospital that it's acquired because of our age, if you think of our aging population and prescriptive practices of physicians. So our piece has always been, I think of the hospital campaign, which the hotel campaign, which is we want you in our bed, well, we want you in your bed, because that is the best place for people. It's where most of their social networks are. It is what keeps them mobile. And so we are trying to actually stop people right at the front door. If we can, we have a rapid assessment team, certainly in the ED here in Sydney, where they can assess and make that determination as to whether you actually do need to come in. We're hoping in the future this year to include it in our planning for expansion of that to support physicians in their offices. And that's some of the discussion as we enter our own budget discussions. We work with multiple partners, so we do work with the home care agencies and that would be our care coordinators and our joint discharge operations team, wherever those care agencies may be, to help provide care in an individual's home environment. We are challenged oftentimes with families working away, and they come home and they see that mom or dad has deteriorated, and because they're going back, they want them placed so that it's less stress and worry for them. And so we have found ourselves in situations where individuals will have no home to go back to. And so that's also where we've talked about partnering in terms of housing to give people some different options. Not everybody requires a nursing home, but they may require something that's more around assisted living or assisted support in a safe environment. With respect to nursing, we do partner with Cape Breton University. We have advocated for the support of the registered nurse seats at the university. There was a provincial review of the number of nursing seats across the universities in the province, and we were able to retain the number that we have. I believe it's 70, but we offer the graduates from CBU, all of them full-time permanent positions. So I think that's 70 from there this year, and as well we also visit, Antigonish, Dalhousie, PEI, because they had a number of new graduates there that were looking for employment. If we see in the media there's going to be layoffs in anywhere across this country, then we're there and saying, come home. And we actually reinstituted the referral system. So if somebody knew of a registered nurse that may be willing to come home, then to let us know, and we would, we'd make every effort to recruit. And there's an incentive that comes with that.
Thank you. Would recognize Councillor Kagan.
Thank you, Mr. Chairman. I have a question and then just two comments I'd like to make. First of all, I would apologize for not being here this morning, but I was at Outpatients in North Sydney, and was in and out very quickly. My question is, does Dr. Ron Stewart work for CBU?
He occasionally consults out there. I don't think he officially works for CBU. He's on staff at Dalhousie University, however.
Okay.
If that's...
Thank you. Now, my comments, Councillor Cormier brought one back that happened, I had happened 25 years ago as a North Sydney Town Councillor, and it was the fact that the mother in the house was put in a nursing home, and the only place they could find for her was up close to Halifax. Have you two people living together since they were 16, and the partner is gone, and he's left totally confused, so confused as a matter of fact that he had thought she died and nobody told him. You know, that's a pretty sad comment and statement on society. Do these things still happen?
Kendall, do you want to speak to that one?
It's a 100-kilometer rule, right?
I guess I can't speak to, those exact situations, but basically for the whole placement process to nursing home, it's provincial policy, and the way that it's set up ultimately is if you're in hospital and you're waiting for placement, you could be placed anywhere in a 100-kilometer radius, which I think was the point made earlier. So that's sort of the criteria that's met there. If you're at home waiting in the community, you can identify what your nursing home of preference is. Now, there are some situations where if someone is really in dire straits at home and they show up ultimately at the emergency department and become a priority to be expedited to the top of the wait list. And again, the thing we have to remember, I guess, is it's a chronological wait list right now that we work with for nursing homes, which could take anywhere from 2 to 3 years realistically to get to the top of it. So if it becomes a priority placement, there is a possibility that you could be placed anywhere, you could be placed outside of Cape Breton Island, but would be made a priority to come back if possible. So I can't really speak to the certain situation, but I can kind of, that's basically the how the policy is set up right now.
But it must also be understood too, people who are trying to help these people have no knowledge of any system or how it works.
Mm-hmm.
And before there's a problem is corrected, the individual is gone.
Right.
That's my final, I have one more comment if I may. Every year, provincial governments go to Ottawa on bended knee looking for transfer payments. And I'm not going to condemn any one government more than the other. But our foreign policy program provides everybody in the world with more money than they can spend. They can give it to this country, that country, no matter what they do with it. But they can't spend it in Canada to help, for example, the problems we have in our health care program in the province of Nova Scotia. I don't know if a lobbyist could be hired to find out the reason why. But I'll bet you if you lived in Afghanistan, you'd have no problem finding it. Thank you.
Thank you, Councillor. Would recognize Councillor Doncaster.
Thank you, Mayor. I'm just trying to get my head around a situation I ran into. I have a friend in the hospital for maybe the last 3 months. I think he had that Billion-Garium's disease. I'm not too sure if it is. It's like his fingers can move and his toes can move, and that's it. And he's been waiting for a placement over to Sydney Mines Rehab. Now, another friend of mine who has a bad hip for about a year, he walks with a cane. Now, I just found out he went over to Sydney Mines this week for rehab. Now, wouldn't you think the gentleman is in the hospital tying up a really good bed, that is not mobile, wouldn't he get preference over the gentleman with the hip? Or is it sometimes with the doctor, they're a family doctor, that maybe more pull or push to get him into the rehab?
There's a process there too. There's a specialist in rehab medicine over there, Dr. Watt, and his team. So the issue is to come and assess each individual patient according to what kind of program they need, and what would be the possibility they'll get a good benefit out of it.
Yes.
So some people are clearly in a situation that, unfortunately, they're just so run down, or there's so many things against them that even the best physio program is not going to help them too much, and yet you've got these other folks who probably would benefit. So they're up against this every time they assess somebody. Perhaps that happened in this case. So it's really in the assessment process, I think, where the holdup is. So if you inquired, you could probably find that out from the clinical lead on the floor as to what
Yes.
yeah.
But maybe since you're at the podium, the media's been talking about this virus, the flu. Is that here yet?
We've just started to see one or two positive cultures. It's not what you'd call an epidemic by any stretch, but I can tell you that our team is on high alert for this and watching the cultures come through very, very closely. Our medical officer of health is Monica Dutton. It's probably gave a little report this morning at the meeting.
Do we have plenty of vaccine in stock?
At the hospital?
Yes.
Now that's one
Or
I'm
in
not
the
sure.
area itself, you know?
Yeah. I know that we had our fair share, and pharmacists are still giving it.
Yes.
I would have to refer that one to Monica. I mean, I know there was a huge run on it just lately because of this national media attention. Do you know that?
Yeah, because I know it's at the doctor's office yesterday, every time the lady comes to the
Counselor,
door.
can you just come into your desk? Sorry, Counselor.
Lady who comes to the door and says, if you're here for the vaccine, come in here. So that was a big rush yesterday.
Yeah. I know they're making every effort to keep up, and there's a daily update on it, so.
Thank you, Doctor.
Thank you, Counselor. Would recognize Counselor Rowe.
Thank you, Mr. Mayor. Thank you to all for the presentation. Very informative, very educational. In fact, you know, we talked about, we got a document from Dr. Monica Dutt about the predeterminants of health, and she talked a lot about education and exercise and all that. And I've often heard my parents say to me over the years, an ounce of prevention is worth a pound of cure. So if more emphasis was put on, you know, us getting to this stage, you know, we wouldn't need hospital beds and home care term beds as much as we do. But the situation we're in now, what I'm hearing consistently is that we need more resources for home care support. And I'm living that daily right now. I had a discussion with Kendall during the break, so I'm not going to go into all the details about it, but there is, you know, the Cape Breton District Health Authority is there to help. You know, they want to help to keep elderly people in their homes rather than going to these long-term care beds, but the resources aren't there. You know, they're okay to authorize it, but the resources, the training is not there. So that's where the provincial government needs to put their money, I believe, is into training people, and people are desperate for jobs. There's a field, there's an opportunity there for people to get trained in that field where we really, really need the people with the skills to take care of elderly people in their homes. And I can't emphasize that enough. You know, we're trying desperately to keep our parents at home. We've turned down 3 calls already for long-term care beds because we think the best place for them to be is at home. But we really need more support, and mostly we need it for the overnight part because most of us, thankfully, have jobs in Cape Breton. And so it's difficult if you're working every day, you know, to be able to stay there all night and look after them. But that's a very big gap in the healthcare system, is that part, that overnight part. There's people who can come in-home and do, you know, light housekeeping duties and meals and all that stuff. But when you have people who need 24/7 care, that's where you need to put more money into the resources for that. Thank you. And I just have one quick question about the mixed gender. It kind of slipped over that. I didn't go into any great detail on that for the beds, the mixed gender beds, and I've gotten a lot of phone calls about that, people really upset about that situation. So I wonder if you could elaborate on that a little bit, please.
2 things. One is we need to get you to the right bed, and then what we learnt from C. difficile is that we shouldn't be moving patients from room to room. It increases the risk of transmission. So, and then, actually, third thing is when the hospitals were designed, and this one's only, is it 13 or 15 years old? There are not sufficient single rooms for isolation. And so we have to prioritize who gets a single room. We use them predominantly for our patients who may have an infection or need to be isolated while we determine whether they have an infection. And that means when we get a call from the emergency department to place a patient, that the patient's placed in the first available bed, and then we do not move patients. And that's the reason why, because of the increased potential for infection or transmission of an infection. In the emergency department, in our ICUs, in our CCUs, in our recovery room, in our day surgery room, patients are mixed anyway. So it's really in the medical, in our medicine units that we see that predominantly.
Okay, thank you. I appreciate the explanation. I'll know now what to tell people in the future when they call. Thank you.
Thank you, Councillor Rowe. Now I'd go to the second round with Councillor Cormier.
Thank you, Mr. Mayor. I'm an optimist, and I don't want to appear negative. And I realize you, with Dr. Calvert-Sims and Dr. Dunn, who's a legend in Cape Breton, and with young talent like Kendall, that you have a lot of expertise, and you are committed. There is no doubt that you're committed. And when you talk about the collaborative emergency centers, a couple of observations, and I think you alluded to one of them, is one, I think you have to convince the doctors to go this way, and you alluded to Dr., I think it was Stephen McDougall, you didn't mention his name, he was one of the first to do same day appointments and next day, so that's key in collaborative. And unfortunately, and the people around this council are going to be really tired by the time I'm finished with the baseball analogies. But unfortunately, I think you're short-staffed. And so in other words, I think that unless the staffing in collaborative area, especially in Waterford, gets a little bit better, you're missing a few pitchers and catchers. That's all I want to say. Thank you.
Thank you, Councillor.
I would agree with that. But what's an interesting piece to note, that as far back as 1980, there were recommendations that we change how we deliver physician services, and here we are in 2014 still trying to make it happen.
Mm-hmm. Thank you. Yes, feel free, Dr. Dunn.
Yeah, thank you. So, physicians work primarily as independent contractors. And that's an issue when it comes to trying to design a service that'll serve the community versus what will serve that physician's personal practice. We're seeing more and more younger physicians come out on what we call an EPP. That's a contract with a government that has certain deliverables. And I do see the day, and more want that. So I do see the day when you will be able to put in those deliverables for the contract. You will leave spots open. You will, construct your practice so it serves the population better. I think this is an ongoing process right now. And that's probably the single greatest reason why the district has difficulty sometimes organizing in a flow of patient care the way they'd like to see it. Is that physicians, they're not really employed by the district. They can deliver good service individually, but sometimes it just doesn't work as a system as well as it should.
To me, that's one of your greatest challenges. Yeah, good timed out there. Councillor Alda MacDonald.
Thanks very much, Mr. Mayor. And I'm just going to go back and ask a question that I asked the first time around that was missed. Just in reference to the 811 number and the amount of people that are attending emergency that shouldn't be or don't need to be, and if they could be using that program. I'm just wondering how effective it is, or if there's things being looked at to change it to make it better or make it more aware to the public. And also, I guess, something I wasn't thinking at the time when I first asked the question was, and I'll speak to a particular issue of a request of mine, which was kind of a strange request. And it came from the building right next to us in the seniors high-rise, someone that has home care come in. And I've had 2 calls from this individual in the past month in regards to his home care worker putting his wash on. His term was up when the clothes weren't dry, and his clothes are in the dryer, and he wants to know what I can do to help him to get his clothes. Kind of a funny request, but he refers to that he's calling 211 for home care help. Is there a 211 number? Are you guys associated with it? I've never heard of a 211 number. Is that something that's factual? Do you know of? And
I don't know anything about a 211
Okay.
number.
Okay.
but if he has a challenge with his home care worker, he should be talking to the agency.
Yeah, well, he referenced that the agency was a 2-on-1, so
Okay.
I never heard of it, so I thought maybe I might get some clarification.
I
Just
don't
maybe on
know.
the
We'll actually ask when we
Yeah.
go back.
maybe on the 811, if you can maybe,
I don't have the data in front of me, but we do get regular reports on 811. There is a perception that it's not well used. It's not as well used as it could be, but it's used more than you would think. I've only had, personally, I've only had 2 complaints about the service, and one was because of a question around location, and they didn't appreciate the person was phoning from Cape Breton, and they wanted to send them to downtown Halifax. But aside from that, the feedback that we've had and the feedback that I see in the reports is positive.
Thank you.
I can't tell you that it's stopping emergency, because if the person can't get in to see their family physician, they're still showing up at emergency.
Thank you, Councillor. There were some items that I would like to ask about specifically. With Cape Breton University and the nursing program practice, and I do know, as was referenced about the good doctor on the north side and involvement, Ron Stewart, with the collaboration between Dalhousie, I think there's some working efforts with Cape Breton University at a medical level beyond the nursing level, which would be very positive in building on some of those wider government initiatives, especially to get people practicing or doing some of their training or practicums in this area. But with Cape Breton University, I would assume there's a tie between the DHA, the Department of Health, and the university and the actual College of Nurses in nursing in terms of the number of beds. You're talking about the needs you have. So what process do you go through so that Cape Breton University, I know the question was raised, but has Cape Breton University increased the number of seats they have for a nursing program based upon the demand you're projecting? Who gets involved directly in that is my question.
Who gets involved in that would be the university in terms of their own planning, with the Department of Health and Wellness, because they also influence it, as well as Department of Education. Sorry, I'm losing my voice. We got involved, we actually sit on the advisory committee with the university here, and we've always had representation on the CBU board. Rex has been on, John was on. Formerly, I'm now on the board of directors now. So, that's one process, but there is an advisory group for the nursing program, and we do have direct representation on that group. There were discussions, I believe it was 2 years ago, about the potential of reducing seats, and we advocated very strongly, and we were able to provide our data as to why they shouldn't be reduced, and that was from the province's perspective, and supported CBU in their application to maintain their current number of seats.
So, and the next tier from the nursing, I'll go to physician recruitment, really is nurse practitioners. And just wondering, in terms of the role that they're playing within the district, the numbers currently versus the numbers you would project you would require, and the effectiveness of nurse practitioners to be that intermediary to take some pressure off. I wonder if you can comment on what nurse practitioners are at. Are we at the level we need? And what is it going to take to get more in place? Is it working?
I'm trying to think of a 1-minute response to a 20-year mission, because I started working in northern Newfoundland, so I always worked with nurse practitioners, and in Alberta. 2 issues. One is helping the public understand what a nurse practitioner can do, and then the second issue is dependent on how the legislation is set up. In this province, the legislation, provincial legislation, for nurse practitioners is set up such that they must have a collaborating physician. And that means somebody that they're going to be working in partnership with. They can't work independently. That's not the same for every province, but that is this province's legislation. And so part of the challenge in introducing the role is being able to demonstrate the benefit and how that role works, and then making sure that you have a partner physician that is prepared to work in that environment with a nurse practitioner, and then helping the community understand what benefits that individual can bring. Does that help?
Yeah, just in terms of how many do we have now and how many would you project
How
you would
many we
like?
have now is just 3, 4, 5, 6, 7. I think potentially we have 8 positions, and yes, we could definitely increase those
Okay.
numbers.
Okay, and the next thing, probably for Dr. Dunn, on the doctor recruitment and where we're going to be, when the notion of moving away from a number of DHAs, the DHA system that's currently in place, and evolving to what I believe is a suggestion of a provincial system of capital, I believe IWK Grace always being separate in the system because of the unique nature, but all of the rest of Nova Scotia being potentially a DHA. How does that affect, one, on a structure? What does it do in terms of the types of needs by a region, a zone, to be able to identify your needs and address them when you start going beyond what you can manage in a district, Doctor? I guess I'm just wondering what your thoughts are.
Well, that's all I have at the moment, because the whole thing is beginning just now to take shape, but it's an excellent question, and initially I had felt that most of the initial changes would be all superstructure, and that we wouldn't see too much change in clinical services or physician manpower for a while, but I'm starting to change my thinking based on meetings I've been to lately. The province is undertaking clinical services review in a broad sense now. There's been a lot of it going on anyway, service by service, for example, orthopedics and so on. But now it looks like they're going to take a provincial look at everything from general surgery to primary care, and start making decisions as to, what should this look like on a provincial basis. Again, getting back to the idea of not competing amongst districts anymore, but looking at the whole province as a whole. So what I see happening in the immediate term next year is they're going to stick to this plan of having a provincial approval, if you will, for every new physician appointment. And that's fairly new, just in the past 3 to 4 years, something like that. So that's one thing that they're not going to change. I just heard that this week. That process will continue. But I think the next tier will be, that could affect us, will be what clinical services changes might they make in Cape Breton? Will they decide that they'll ramp up one particular type? And right now the flavor of the day is generalists, general internal medicine, general surgery, getting away from super specialists and concentrating those in just one area. That's kind of where the thinking is. That could affect our manpower a little bit. In terms of primary care, that's been a hard nut for the province to crack for years, because the overall vision is to have the kind of collaborative practices that we've talked about, that might include a nurse practitioner, might include other professionals as well. But to get the physician buy-in, this is going to require contracts, as I mentioned earlier, and deliverables, and I think they'll go down that road. So I think you'll see in the short term, just to recap, continuing controls on our physician recruitment, and less, probably, I would think a lot of the district incentives that we've been offering, once the amalgamation occurs, a lot of those will probably disappear, and they'll all be, they could all be administered by the government instead. So there wouldn't be any sort of doubt about what kind of position you're going to. They may have a whole series of incentives for special situations. That's what they do in most provinces. For example, Neils Harbor, difficult place to recruit a physician these days. But maybe there would be a special incentive for that case. So I think primary care will be fine. If anything, it'll ramp up. I think we'll see strong services here because we have a very good case. We're so far from Halifax, and we have the second biggest center, has been described. We do the second largest number of surgeries in the province right here. So I don't see any huge changes, but there could be shifts in emphasis, and I think we'll see them in the next couple of years. The goals will be set.
So just if you build on, I guess, looking for your interpretation, so when you build on what the type of statistics that Kendall's presenting and be able to analyze how all the different components of the medical system and the collaboration of everything from the emergency room to the nursing floors themselves, to long-term care, to home care, resi care, all of that integration of how it works. Do you have any concerns that the ability to do what you can do now on a district-wide basis of integration could be compromised if it just becomes a province-wide model? Or is there some sense that that is going to be all integrated?
I have a sense that it'll be integrated. I know that for a fact, at least from the physician side of things, the integration of the community care facilities, whatever they may be, and the district is not as strong as it is in some areas. We have a lot of improvement that we could do there, and that has done a lot in certain districts, mainly in Capital, to improve the patient flow in terms of people that need to be transferred from one facility to another, maybe avoiding that because there are physicians available to look after those things and there's a schedule and all that. And that could spread province-wide, just as an example. I don't think there will be in the short term any intent of this new initiative of the government to shortchange us in any of those things. And I can see some significant potential for improvement of many of our services.
I think that's important to know, because sometimes you worry, are you losing?
Yes.
By going into a broader realm of administration and oversight versus what your needs are on an operational and a service delivery basis day to day here within what is the current district that I think has been working effectively. But those are decisions that are rendered, but we also have to look at what the practicalities are as well.
Well, if I could look into a crystal ball, I'd love to know what it would show, how we're going to do with 4 divisions and 1. I don't know how that part's going to work.
Right. So we've got
we all have a healthy degree of skepticism as to whether this will really be more efficient in the long run. But looking at it from the service perspective, which is where I live, I think there are a lot of thoughts going to go into where services should be provided. For example, should we have a solo thoracic surgeon in Cape Breton or a solo neurosurgeon? These are legitimate questions, and these kind of things will be addressed. I think to the benefit of our patients, really.
No, I appreciate your frankness with that. That's it's going to be important to go to next steps. And just as a closing note, when I talked about other opportunities, I know some of the things you talk about partnerships, and I see Mike McKeegan here and his team, when you talk about HandyTrans and the pressures we have, that we have run an effective service, but it directly gets linked into providing those support services that are essential in an effective healthcare delivery model, and we're seeing greater and greater, as your statistics would show, so too does the pressure come. So as you step up to partner, so do budget pressures go with them, and that is something that we're ever mindful of, and we hear that often about how do we make sure we provide those levels of service. So from a partner point of view, there's that. I also think of the policing aspect in terms of the role that the police play and the services they provide that end up becoming cost pressures to the municipality. You can go right into the public works aspect of items that become into public works, you know, the wastewater, those types of things that have been traditionally not part of a budget pressure but taken on. How do we move on that? And I think that's part of a wider dialogue that I hope we will have with the province about how do we address these service delivery pressures. Because we can't just solve our health delivery needs in these silos, because if we're going to be a community that is integrated, working with the district health authority, working with if an expanded model, it has to recognize that as we want to step up and service a growing aging population, the pressures on our bottom lines are not going down. In fact, they're increasing. And if we're going to do it effectively, we've got to say, how do we come into that? And that's not a DHA role. It definitely is our relationship with the government. And as Minister Fury comes here in February as Minister of Service Nova Scotia, these are things that I think we need to address that are coming as pressure points for us, yet we want to be a partner to make sure that the type of statistics that Kendall's put forward, the type of items you're talking about, are actually improving for our citizens, because there's only one taxpayer here. And that ultimately is the thing. They don't see the difference. They just see tax bills and they feel that we all have to play our role. But because of legislation and jurisdictional and operational areas of responsibility, it sometimes clouds the waters. And I think that this is a good way to open that dialogue today. I believe it's a next step, but I believe it also probably leaves us today with much more questions as well that we'll have to try to address. And I'd appreciate any time that there's a need for follow-up, you would let us know, and we'd welcome this opportunity another day as well. So with that, I want to thank all three of you for being here today. We appreciate your time and for such an important topic for all of our citizens. So thank you again.